Okay, thank you very much for coming. First up, Beth, where's Beth gone? Beth is still there. Beth, you have pleased me immensely. Do you know why? Because you made sure the parrot had something to perch on in every single slide that you did, and it's very important that you get it right. And that's pleased me immensely. That's the first thing, the most important thing I'm going to say. I've got a truncated time period because somebody over talked too much. But hindgut fermenters for the rabbits, and we need low quality, high fibre diets for them. I'm going to go through relatively fast, but you'll have some pictures to see. And obviously, if you're dealing with anorexic rabbits, you need to get your phone, when you're dealing on a phone call with them. And there's just some key questions you need. You don't really need masses of questions. When do they eat? Have you tried favourite foods? And what does its poo look like? And obviously ensuring the owner knows what is poo and what isn't. Secatros, which is what we have here. The immediate response to most anorexic rabbits is, let's get some food down them. And the owner either will do it, the vet will advise it, or the vet will just do it and just stop, basically. Don't do that, is my first thing with these cases. And I suppose the reason for that is one of the major reasons that we would see crashing rabbits coming in, if you're dealing with severe GI disease, is aspiration. Because basically you've got something that is sick, collapsed, not really capable of taking in food orally, and all you do is shove food in it. And that just doesn't work. So for a crashing rabbit, the last thing you want is a mouthful of oxbow that you're trying to intubate past. So yeah, we've had rabbits that have died as a consequence of being syringe fed inappropriately. So if you're worried about this case that you're triaging on the phone and you're thinking, okay, maybe this isn't just anorexia, maybe this isn't just a mild gut stasis, then it comes in. But it doesn't want syringe feeding before it's come in. And basically, it's very, very easy to identify a rabbit which is a potential surgical case or a surgical candidate. All you do is you just do that behind the rib cage. That's all I need to do. I've made my clinical judgment, and that singular part of the exam is going to massively influence how I manage that case subsequently. So if I'm in doubt, I just want to feel the size of the stomach. And if it's obvious, great, then my whole management is going to change from that point. We're going to skip through some of these, like I say, because the zoo closes. So I can tell you those 5. It's normal, it's empty, it's impacted, it's bloated, and it's just less full than you'd like, but it's not got gut stasis. That's your outcomes. Consultation, you kill it, you keep it, you cure it. That's your 3 options. There is no other conclusions from that consult. And that's all you really need to determine. If you're going to have an animal in extreme crisis, you're having the death chat, that's kind of where that consultation is going to go. If it's one you think, I'm going to send this out back again, then obviously then you've got to go through, get your diagnosis, do your clinical exam, work out treatments, send it home with treatments. If you're going to keep it, you don't have to make those decisions then because you've decided you need to keep that as an inpatient anyway. Those decisions you can make later. So you don't have to delay admitting it, or delay warming it, or delay getting analgesia on board because you're insistent on taking a 20 minutes history and a detailed neurological exam. It's like, it needs to say, let's get it in, let's actively treat it, and all these other bits of information can follow afterwards. So, in other words, you've made a decision if the animal is a keeper. See what I did there? Really hilarious. All of these GI cases will be cold. Now, most of your standard GI stasis, maybe 37, 37.5, not horrendous, but they will be a bit subpar. If you're genuinely blocked, they're markedly hypothermic. I mean, these are poorly sick rabbits. That's immediately obvious, overtly obvious on clinical assessment. And to be honest, if you chat to the owner on the phone, probably overtly obvious from that too. So we want them warm. Maybe start off with a snuggle safe because your incubators will take time to warm up. They will all be dehydrated. You probably want to give them all fluid therapy. shave their ears, get the EMLA on board, and I do it in the consultation room. So if I'm seeing an rabbit in there and I know it's going to come in, I'm shaving ears and I'm applying EMLA in the consult room. There are two reasons that I do that, and they are to the left and the right in that picture. Because then it's done, it's started, it's cooking. So your EMLA isn't going to delay your treatment, because if it's hypothermic, you can't get access to the veins anyway because they're flat. So shave the ears, EMLA them. The EMLA will vasodilate as well, of course, because it's local. Get it in the warm. Give sub-Qs if you want to start, if you really feel the urge to. But then everything else can flow from then on because you kick-started getting ready for catheters already. Oh, yes, see, it was always going to do that, wasn't it? And do that. MacBooks. You know how to do this, Beth has told you. Okay, so your emergency treatment for these, bloated rabbits, and like I say, gut stasis is different. For the bloated, no non-steroidals, we've probably got risk of gastric ulceration already. Fill and full of morphine or methadone. I love ketamine. Paracetamol is good. But you obviously, if you're worried about is this sedation, is it collapsing, well then just give something. You can always titrate your doses more after you have really assessed it or after you've done decompression on a bloated rabbit. If you're in and it's not bloating, then fine. Analgesia, you can go ahead with meloxicam. Buprenorphine maybe is adequate. Ketamine is okay. And again, I put midazolam down here as well for these. I cannot remember why the chance card is there. I honestly can't remember why I put that there. There's clearly something hilarious I was going to say. And I don't know. Maybe it's because you've just got out of jail and you don't have to do a bloat case. Bear in mind your bloat cases can go across to this side, and these cases can go across to that side. And if you've given your creature buprenorphine, and then you decide it's surgical later, you've kind of messed up your chance of having a pure mu opioid on board. So you're going to have to just plan different analgesia for that case. CRIs, yes, work well for the really painful ones. For the rabbits, it's difficult to put them on a giving set because they chew it. If you're really collapsed, you're not going to chew it, so they're maybe the ones that do need it. But certainly peri-surgical, post-operatively, you can keep running these, and when the rabbits awake enough to chew it, then you've probably served your purpose anyway. Give them pain meds, warm them up, give them fluids. And like I say, it's at that point, then it's like, I've done that, then I've done my clinical assessment, and then I'm in two different directions. Stasis, then you can throw your syringe feeding at it, then you can throw your prokinetics at it. That's all perfectly fine. The surgical cases, they're not surgical cases, but they're on bloat watch. It's a bit like spring watch, but far less exciting and more tiring. Some of these you might want to emergency decompress. That's doable. This is quite older pictures. I'd have oxygen on the nose by now, and this probably would have ketamine, midazolam, and methadone on board anyway, or something like that before we started. Decompression is aiming to basically clear out the buildup of gastric secretion, so liquid. You just have to be careful. These block very easily with fur, so you just have to sort of take it slowly. And sometimes with these, I'll actually re-inject a little bit of the gut contents that I've aspirated just to blast the fur off the end of the stomach tube. And I like and also hate blood glucose. It sort of has become this thing that you measure your blood glucose, and if it's high, it's surgical. No, it's just showing how, I guess, physiologically decompressed this animal is. You get hyperglycemia, hyponatremia. Yes, they determine prognosis, but if you're taking this on a continuous basis, you'll see this peaking and troughing all the time. So, okay, maybe it's a guide, but what is a good guide for where you need surgery is that, followed by whether that is getting bigger or other signs that you've got. And for the bloat rabbits, we get acute kidney injury. You need to be doing urea and creatinine. Okay, maybe before you start, but to some extent there is the argument that, well, if it's bloated, I've got to do surgery anyway. It's dead if I don't bloat, don't do the surgery, but certainly afterwards you'll see that. And we've certainly had rabbits crash during decompression surgery because you've had a sudden blood flow, blood dynamics have changed where you've actually managed to get venous return back to the heart again. If you're really not... Oh, where is Kira? I'm going to... No, it's just I'm obviously touching things I shouldn't touch, and it's Apple, and Apple hates me. If you still don't know, X-ray, okay? If you've got big lots of gas, you're not bloated, you're a GI stasis. Okay? If you've got blockage in your small intestine, which is where you're going to have this really, then you cannot empty your gastric secretions, and you have gas then floating on top of that. I didn't need you, I was just getting cross because of the MacBook. That's all it was. I just wanted to express my disdain for MacBooks. But again, go back to the gastric ulceration here, you can start to see here, this is like close to rupture city here. So your decompression is to ease pressure on that system while it either clears or not. And we've actually, quite nicely in this shot, also have ballooning small intestine as well. So you have to clinically make a judgment call. There's no right or wrong here. At some point you go, this needs me to decompress it surgically because it's not working medically. And that might be 10% of these cases. Okay, that's 10% of the cases that have got sky-high blood glucose that you've been told are surgical. Okay, the other 90% aren't. They just need really good analgesia and management. But for this has got to the point you're like, no, I've got to decompress this. And then your surgical choices are twofold. You either go to a deal with the blockage first, which will then deal with the need for decompression at the same time, which has avoided you opening the stomach, or you just go for the slash and grab and decompress the stomach and work out the blockage later. The choice is yours. Make your choice as a clinical judgment under anaesthesia. Decompression, you can needle aspirate, you can suction with a syringe in theatre, but the aim basically is get the pressure out of the system. That's the first thing you need to do for them. Or let it just spew out all down the side of the table. Have some Inco pads, towels, this sort of type thing. Make sure your nurses don't hate you. And then after that, and you've sewn it all up, you're hunting for foreign body. Okay? And this isn't a foreign body, this is fur that's wrapped around feces that's wedged in the small intestine working its way down. Okay? This is what you can find down there. Quite an unpleasant looking piece of bowel. That may or may not have the obstruction there, because the obstruction can move. And this is what I'm saying, where they can flip between both sides. They can block, and it'll suddenly squeeze down an extra 4 or 5 centimetres, and therefore much better, and then it'll block again. And it might do the same again. And it might do, by the time you go into surgery, have moved and become loose, and you're like, well, it's not blocked anymore. So it's really quite frustrating is that this can block. It's like a train that can stop at any station on the way down. You just have to pick your moment of when it goes through. So much as you might feel inclined to remove it, which is great, but rabbit small intestine is not as easy to deal with as stomach in terms of risk of peritonitis or how forgiving the tissue is. The vast majority of cases, we would be aiming to take that blockage and gently manipulate it down through the sacculus rotundus into the cecum. Because once you've done that, your problem is solved. So if you can avoid small intestine surgery, do so. But obviously we're fiddling about here, but this is pre-blockage, not very happy, pre-blockage, blockage, post-blockage, not a lot going on, and you've gently got to encourage this to move and weed it all the way down and through for you. So this is what you're sort of dealing with, and like I said, that's just being progressively, slowly fed down. If you get too impatient, too quick, you'll damage the small intestine. You need to make sure you're driving in the right direction, because I've gone backwards before because I've got completely confused because it's not in a straight line, and you've milked it halfway down and gone, oh, this is working really well, and then you sort of look away and come back and you milk it back up again, and then you wonder why it hasn't worked. So make sure you get that right. But once that pops through the sacculus, then the whole system just flushes through. Now, if you have done a gastrotomy and emptied everything out, there is an argument that's better because you've cleared out all the next lot of fluff that's going to fill up the, could do it again. But equally, of course, the rabbit's still got fur on it. It's still going to do, there's no guarantee it won't do this again tomorrow, or next week, or in 6 weeks, or in 2 years. Okay? So it goes back to grooming and management of the molting rabbit, really, for these as well. It's 1 minute left. No to both of those. No point, unless you feel that a rabbit breaking wind with a single gas cap is less painful than multiple little bubbles coming out. You can make your decision on that, but they don't burp. So it's got to go out the back way, okay? Speed, but I've done it. It's got a T-perch, right? It's got a T-perch. I had to fiddle to try and make that all fit together to look nice. Clinical judgment, not blood glucose, lots of intensive care, lots of analgesia, decompress and surgery as you need to, but it's not a guarantee. Thank you for coming. Shona. Thank you to sponsors.